And with that, I would like to welcome and thank my co-presenter and the lead on this, Mohamed, who is here with us from the Office of Equity and Inclusion this morning. He will be kicking it off for us today. Thank you.
Thank you. Thank you everyone for joining this session. I think as you can see, the title of the session is basically acknowledging the role peers and peer wellness play in organs health system. My name again is Abdiasis Mohamed. I work with the Organ Health Authority, Office of Equity and Inclusion. I'll be the main guy. He got willing to take all the bullets and frustrations that many of you have witnessed and came through the system when you are seeking for your state certification. Part of this session today, and that's one of the things that I am in charge of, making sure the certification of PSP wellness and then other tradition health workers, which we may use a little bit here and there in the state, are responsible for it. I want to acknowledge and state to all of you that if any of you feels like you want to, vent on your frustration of how it is not working, I'm here to listen. My job is to listen and acknowledge that, as well as continue to find a way to get, feedback, suggestions from the participants and, and everyone else in between. What can we make, to make it better for people, this certification. So, and then also technically, like I will talk through a lot of several slides that we have for you here, but above all, the certification part of it is in there. And then other key things that, peers and roles play within the state. So those are other things we will discuss through this session. My co-presenter, Ms. Adrienne, also will take some part of it regarding peer supervision and other stuff that we intended to bring into the session. And in the end, my hope will be take the questions as we go, so that we will be able to answer most of the questions all of you may have. So that way, nothing, feels left out. So that is what we would be going through for the day. With that, I would love to go to, looking at the first slide you all have. It kind of shows you how peer support, one other thing, let me take a step back. Many of you may hear a lot about what is traditional health worker, what is peer. We are all confused. What is family peer? What is this? So the state of Oregon uses an umbrella term to put together all, preventative and behavioral health workforce in the state of Oregon under this traditional health work umbrella, which is, we have traditional health workers, but family peers, youth peers, peer wellness, as well as peer support in our adults, addiction, adult mental health, all fall under this bucket of the traditional health worker that the state uses everybody to lump them in that group. And particularly, we have other traditional health workers who are part of that bucket of, under the umbrella. These are like community health workers, if you have had them before, or doulas or other people. But for the purpose of this session, we're going to focus on peer support specialists with our addiction mental health, as well as family support, youth support, and then our peer wellness. That would be the focus of this. But you may see areas where traditional health workers might be mentioned. It's just particularly, this is all an umbrella term that the state uses to understand, how we work in terms of state of Oregon, which is a little bit different from other states around the nation. You wanna go to the next slide, Miss? Okay, so the goal would be, define what are the community-based integrated behavioral care healthcare delivery models we have, and understand, why peers are very much important in the equitable of health outcomes that we all want to foresee in terms of addiction, mental health. And then define, the different categories, the roles of traditional health workers, mostly peers and peer wellness. And then, we'll share some, current trends around peer wellness workforce demographics statewide, which, peer and peer wellness trainings. And then I'll share, PMP wellness supervision, which we will talk a little bit around that. And then lastly, you know, kind of give you an overview of some current payment models that exist for PMP wellness, and then the utilization of peers, you know, and challenges that peers face in them in places. It is hard to condense everything in 90 minutes. We hope, you know, whatever we miss, my contact information and Adrienne's contact information would be available to you all. You're always welcome to email and send us any question that or any piece of the presentation we failed to address for the day. Next slide. All right. So here's a quick question that I wanted to ask all of you. I call it food for thought, but it's more a little bit of getting to hear your perspective. Where does Oregon rank in the nation in terms of mental health and addiction recovery as of June of 2020? How many of you know? So if you feel you know this, please help yourself to unmute and then answer, shout out. Like, where do you think? We have about 50 states in the nation. Where do we rank? Are we in the top 10? Are we mid? Are we like, where are we? So if you want to share, please feel free to unmute yourself.
Third. I say third.
You said third. Great to know that. Who else?
I'm going to say top 5 at least. Top 5. I've lived in a lot of different states.
Top 5. Go ahead.
I want to say number 1. If not, let's get there.
Number 1. I like that. Anyone else? Any guessings? Anyone else?
I heard it was pretty high, to be completely honest with you. I think the last statistics that were out, Oregon actually had a really, really poor ranking as far as mental health addiction recovery.
Well stated. What number would you grade us? If you are today the governor and deciding we need to be up there, we are from here, what number would you give us?
I would say probably in the 30s.
In the 30s.
I'd have to agree with that. I'm thinking around, you know, the 20th, maybe rating rank around that number.
Interesting.
I think
Probably
we rate,
around 24th or 25th place.
24th. Penny.
I think maybe 22. I think in the rural areas it's a lot. I think the metro areas are doing pretty good, but the rural areas we could use some improvement.
Well,
I'm wondering, just wondering what the qualification is for ranking. I mean, what are we talking about in terms of recovery? Is this a number of people in the hospital? Is it a number of mental health?
everything.
Yeah.
Like a bulk of, you know, how the state is doing in terms of like addressing from behavioral health perspectives in terms of, you know, people getting the right support, the right structure, the right, you know, things that is needed for them to really have a full recovery. That is what they looked at. We will unveil. We will unveil.
I say 7.
You will say 7.
Okay.
Okay.
I think we're really low.
37?
37. Well, thank you though. I like the optimism. All of you are like energized, you know, putting it in where are we, and we need to be better than every other state out there to really address this issue. But can you go to the next, Miss Adrienne? So before we go there, go back a little bit and I will answer that. Go to the previous slides here. So just so you know, with someone who works for state government, we rank number 48, which is very sad. 47, we are in 47th right now in the nation in terms of, as of like, you know, June 20, the Kaiser Family Foundation did a lot of work, did a lot of research using both state data, federal data from SAMHSA and other things to rank, you know, which states, where are they at? We are in around 47, which is like very sad. So just, you know, I didn't mean to put down your optimism, but we are not doing very well in terms of when we talk about suicide prevention, I mean, with the substance use and addiction recovery, as well as mental health. We have a lot of, we put so much energy, but we have a lot of people out there, but it's not panning out the way it's supposed to be. So we are in 47 in the nation as of like June 2020. And the biggest impact, which we will talk about later, is with even with COVID, it has exacerbated the challenges that we were coming way up, but then, with COVID-19, it has exacerbated it more. Families who used to rely on the schools are now locked up in their own houses. One counselor or one, QMHA or one peer mentor or one CRM cannot be able to support, how many families in their homes. Kids are struggling with mental health. Youth, the same thing with addiction and mental health. The adults who had relied on other social support, they are not there. I was watching, in our group, I believe someone mentioned that she can't wait to go back to work because, since COVID kicked in, maybe being out there for families and for other folks, we're not even out there helping folks. Do their mental health go away? No. They are struggling, they are like, dealing with it. But then the resources is not so stretched enough to reach every family that really, and every individual that deserves it. That is what, why we are ranked so low. And I think we have a long way to go. With all of your support and synergy, I believe we can come up this around. But I have been working with the state government for the last 4 years. Every presentation I made, I have never seen this number really go up, seriously. And I'm like, what is going on? What else can be done? It was between either in the 40s all the time. And I'm like, I think we have a lot of foundation, a lot of structure. What else could be done? But this is the struggle. So I just wanted to mention that, and thank you for all the optimism, putting us in grade number 1 to the 30s to the mid-20s. But just so you know, we have a lot of work to be done. I applaud each and each one of you in your individual lives and services to all you do for consumers in Oregon. Thank you for what you do, and we will have to continue to do more to support more families, more individuals, more youth to really curb the trends we are facing right now. You want to go to the next slide?
Yes, and I see that Joel has a hand up. Joel,
yes.
Do you have a question?
Yes, I do. Can you hear me?
Yes.
Yes.
I'm just kind of wondering when there was the big shuffle, because like in Medford, our VA was ranked really, really high for mental health and addiction recovery, but then they changed everything. So what was the big change? Does that make sense? I'm not really sure how to say it. I know that we are really high and now we're really low, and I'm just kind of wondering what brought that about. And
so you're right. One thing I think I hear around the state when it comes to even working with our coordinated care organization system structure, we have so many disenfranchises of system. Our behavioral health delivery is not robust, well coordinated. We have you may see here, someone may be doing well in Southern Oregon, Medford, but then someone in Eastern Oregon, in Ontario, it's not going great. And then you go to Coastal Oregon, the struggle is there. And then you go to Central Oregon, there's a challenge too. So then you may do well in one part of the state, but there are other parts that resource-wise, I was doing a presentation yesterday, someone saying in 15 years, there was no these services even available in our state, in our part of the state. So 15 years, when people were struggling, even if you bring a lot of behavioral health in now, when the adaptation, the connection, the trust, and the building, that takes time. And so that is why one part of the state cannot fix it for all. Even here in the Tri-County, like Penny mentioned, there's a lot of resources, but is the resources coordinated well enough to really meet the demand and the need of every person? And even those who make this a living because of their lived experience and career, are they really looking this, to support individuals? Are they well supported, well paid? If you are not, then the technical of sticking around for the field and helping other people may not be there. You will move on. That leaves a gap, and a service gap that one person was addressing, but then it's difficult, once they move on, replacing them with another, peers becomes a challenge. That is the kind of snap challenges that we have across the spectrum. So we were gonna move on, and we need to dive into a lot of other stuff. Next slide, and thank you, Joel, for the question. So what is a peer support? So, I borrowed this slide from Ms. Ali Lemford in Kalakamas. So it's a system of giving and receiving help founded on key principles of respect, shared responsibility, and a mutual agreement of what is helpful. So in the end of the day, this one is to kind of, remind you all the work you already do, that, peer support services is not based in psychiatric models, and that's not the criteria. It is all about understanding another's, situation empathically through the shared experience of emotion and psychological pain. So that is one thing I wanted to remind folks as you do this every day. I do see a lot of people coming into the peer world. Sometimes I go around the state to talk to different classroom and presentations, and I ask them, I would give them, some quote I really love, where at the end of the day, if you're not able to walk the talk and, talk the talk and be in the shoes of another fellow, human being who's dealing with addiction, mental health, that dealt the same way you are, and understand them from where they come from, it's a challenging to do the work. A lot of people sometimes will come into the field not for the sake of want to make a change for others, but it's employment purposes. They are like eager to make some money out of it. We have seen a lot of pieces, but that is not to say all peers are like that. But we have seen some people that will come in to the field from other fields, not really embodying the lived experience element. And as all of you know, the state really highly requires, in order for you to be a peer, you have to have a lived experience with either or, whether it's addiction, mental health, with families, with youth, wherever field you are helping others, to recover, you should be embodying that lived experience. Without that, this is not your charter or your territory. Probably, maybe you should look for other fields, because this is all about, it's not the 4 years degree school, it's all about the lived experience you bring in for others, so that you can walk with them and talk the same journey. This is, a model that we always use, Oregon's traditional health worker. You wanna go to the next slide. So this is the initial slide I talked about. This is how Oregon uses when it comes to traditional health workers, but the intent is making sure you wanna click next, so that we can build the bridge of why all of you are a bridge to the system. So you can see that is the structure all of you play in terms of making sure we have the individuals and the communities on the left, the father side, struggling with addiction, mental health, and the lack of support. But it takes this building bridge, and you can see going back. Why are we 48 or 47? It's a long way to go to get there. We have this structure called coordinated care organizations and health systems that we have in the state, which are about now 15 of them in the state of Oregon that oversee a lot of our medical and behavioral health delivery of care. Are they all doing great? I'm not gonna lie to you, they are not all the same. There are some CCOs that do very great job in terms of coming this forth with the intent of real investment, real support for our systems, so that the consumers in the service area really recover well. But then there are those who are still also in the strengths, like challenges, like maybe this is a new charter or a new territory for them implementing in that kind of services. But then it takes time for them to be like one of the other CCOs that are in one part of the state. And it is not unique, we call CCUs and service areas. Each one has its own structure of how. So it is not like a robust, well-vetted, coordinated effort. So that can also add on into the challenges for the average Oregonian to really get a better care and a better services the way they will maybe if they lived in Tri-County, if they moved to Coos Bay, Oregon, you can see the dynamics. Maybe the resources are not as robust as they were getting here. So, but overall, what peers do and peer wellness in essence, the outreach and mobilization with families, having that community cultural liaison, and then the case management, the care coordination, the system navigation, and then health promotion and coaching. Those are the things. So it's basically being a bridge between here on the far right of our coordinated care organization, our health systems, and on the left side, you can see is red. That is the challenges families and communities and individuals face. And we are here in between, making this connection, making these dots. That's what the goal is, yeah. I see Penny has a hand on. We're gonna quickly go to you and then we're gonna move to the next slide.
Thank you. Yes, so we're on the Oregon coast, and our CCO has educated and certified a lot of community health workers. But I know that the Oregon Health Authority wants us to survey and have a more diverse traditional health worker force. But currently, we are only rolling out community health workers, which are amazing and they do amazing work. But it seems that the providers are more accept community health workers more readily because they're sort of more, I don't know really how to say what I'm trying to say, but and I know the OARs only suggest that we use traditional health workers. They don't require that we use traditional health workers for our new social determinants of health program.
So yeah. And I think that is a great point, but at the same time, one of the new requirements for all coordinated care organization, and I can see, this is the challenges a lot of peers face, since we are talking about peers per se today. There are some providers, they put this connotation of, with peers with previous, addiction or mental health history. There's a lot of tendency associated with, okay, peers are not clean, peers are not da-da-da-da. That has exacerbated the challenges for some providers choosing, I'm a community health worker, but then I don't like that sentiment when a provider, when I may not have the lived experience of addiction or mental health for me to really provide a robust services for another fellow peer. And it shouldn't be a choice of someone else because the provider likes X and then the other X are not so-called, the system calls them, they are not clean enough because maybe there's a history of, incarceration and other related effects that really affected people. But then now, what the state do through the coordinated care organizations contract, the one that just kicked in 2020, we require all traditional health workers, including peers and peer wellness, are used to buy CCUs across the state and report on them, making sure the number of each traditional health workers they use, including peers and peer wellness, community health workers. It is not a choice of just maybe one part of the bulk of traditional health workers and then calling them they are great. All of them are great. So how do we diversify in terms of, like the issues, for example, if mental health is not fully addressed or addiction is not fully addressed in some part of the state, bringing the right tool, the right expertise, the right people can really elevate and make a dynamic and shift in terms of those numbers. How can we make sure? And I think for me, someone, who understands mental health and addiction, but when the community health worker role, it is very minimum to very much, where addiction, when we talk peers and peer wellness, their main focus is behavioral health delivery of addiction or mental health support. And if any provider, wants to change the trend, like we talked about bouncing us from 48 to maybe in the grade 1 or 20, we should be aiming how do we come in, like we're not choosing one provider over the other, but how can we diversify our resources so that with the addiction mental health, we are willing to go farther down the road, so that we are stretching and addressing all systems levels of challenges that a lot of community members face. And that is the goal, and that is the expectation that, and you mentioned ORS, there's state rules that cater specifically for organ administrative rules that require CCOs to use this. And then each CCO has a main contract that really calls out that they have to report on this number, how they're using it, how many of these numbers of their THWs, including ever 5 of them, the 7 of them, even family peer, so that they can report and showcase that they are not using one worker type, but they're using all to address, a robust wraparound holistic health system so that everyone wins. So that's one thing I would just respond to. You wanna go to the next slide? Thank you, Penny. So this is, mental health and substance use state fact. You can see that's why we have 47. The bulk part, the only states as far as I know is Florida and Louisiana. That is the bottom of us. And then we become third in the nation, which makes us 47. And you can see Washington, our neighbors, not far off from the blocks. They are like also having the same struggles and challenges. So Midwest, Western Oregon, Western states are doing great. California is a little bit better. But you can see, all the way, the states we will so-called somehow, we will maybe associate them with, they are not so liberal enough. They don't stretch maybe the, Medicaid and other stuff. We are more in the same bucket right now. So I think it takes a lot of work and a well-coordinated effort to make sure we can improve this, bounce us from this, dark blue to some maybe grayer blue down the road. And I think all of you, with all the support, will take a lot of work. Next slide. So this is what a recent, survey, and this is where all the data I've been sharing comes from, that, consistently found that large shares of adults reported their mental health has been negatively impacted due to worry and stress over coronavirus. So all of you know that this was done as of June 2020 in the midst of COVID. So when we were doing before well even, we were not doing great, then you can really see the challenges that it brings in with COVID, loss of employment, loss of, resources, and lack of, now when peers were like, if you had, maybe let's say, one peer for a 50 case managing like between 40 to 20 people, today that peer, I think, only works 5 days a week in the house. The likelihood of them being able to reach every single family in a daily basis is very minimal. So then there are families who will be on the brink of not being heard from. They are struggling alone, dealing with this, in addition, it had added, the COVID crisis too. And then mental health and substance use disorders are like key public health issue. Some states are calling this a public health crisis. Oregon is in that format as well, like the governor has called this a public health crisis because it needs to be addressed. We just didn't know yet how to really figure and address it well. You can see 17 million adults and, and in addition, 3 million adolescents reported having major depressive disorder in the past year of 2019. That's a lot of number. Over 10 million adults deal with mental health, serious dose of suicide in the past year. This is a big challenge, and these are not like far enough. We're not talking in the 2006 era. We're talking about 1 year ago. 14 million adults reported unmet health need of mental health and substance use disorder. This is the challenges we face because what? Like the one I mentioned, we're not far enough to stretch and address amid, everyone else. And then with the amid of, COVID crisis, more than 30% of adults even reported, a lot of anxiety and depressive disorder during the pandemic. So you can see this all exacerbates what we already like the lack of resources that existed, and then it continues the trend a little bit more. Next slide. I'm flying through this so that we can have enough time for questions and answers. And then so the need for mental health and substance abuse care is expected to increase more, just so you know it. And then you can see, 41 28.3% of adults in Oregon reported symptoms of anxiety and depressive disorder, compared to 36.5% of the U.S. adult population. So you can see there that compared nationwide, we have like a high number of 41%. And the share of adults, you know, with the mental health, you can see that one is like 22.4, when the nationwide from last year, 2017, 2018, nationwide it was 19. So we were not doing even well in 2018 and 2017 era. The same thing goes down last there, like our youth are not doing very well in compared to the adults. And this has really, you know, increased the challenges that all of us are called upon to really address, you know, to meet, you know, mental health and addiction recovery work in a more maybe different way approach versus maybe the status quo, because we have a lot of work to be done here, even local in the state of Oregon. Next slide. So this is an estimated, you know, you can see in 2029, we're not doing well. Like this is what the projection is. That tells you Oregon has a lot of work to be done. Like it is not doing very well in terms of substance use and recovery. There's a lot of challenges that we have to cover. You can see it's a rate by 100,000 population. We are in the low dark blue. That tells you the work is a little bit ahead. Next slide. So here I want to talk about the little bit fun part of what we do. How do we certify peers and in the state of Oregon and the training that is required? So generally, all of you know, the state of Oregon provides certification for peers and peer wellness, families and youth support, addiction in the addiction mental health work. And that is what resulted those who are involved in the, you know, billing system within our Medicaid system, which is not great so well in itself, but we do what we do. We can work with what we can. So with our behavioral health delivery system, these are some of the things that are required in terms of statewide, how we deliver and what we need to do. And so all of you, you know, in order for you to be a certified peer within the state of Oregon, we don't call licensing. It's not a word in the world of traditional health workers and in the world of peers are liked very well. The call outs like certification, they are more the same as licensing. But licensing is a connotation that's more affiliated with nurses, doctors, and other in the more medical world. Certification is something that we use so that it's more community-based, connection to the community. That's what we use for. I'm gonna finish this slide, Penny, and then we're gonna come to you. But technically what we require is that in order for you to become a peer, you require to provide, you know, get a training from one of the approved OHA training programs. And then that helps you to provide assessment. We don't take any test, anything like that. It would be the training providing all that basic foundation to prepare you to understand the work and the field you are diving in yourself, that it is not so-called where you're gonna make, you know, in the 60K figure or $100,000 field, but it is about changing life and impacting others to walk with you, you know, in that journey so that they really feel someone out there has been listening to them and understanding them. And so it's not a field people should come in for money. It's a field for, you know, making a difference for others, to really see, you know, you help someone to really recover. That is the goal. And so the trainings provide these basic elements and foundations. And then with the state certification, we do have application process and other stuff, which I will dive in later. And then we will dive more about it, this part of it. And then when it comes to, you know, employment, peers work in various, peers and peer wellness work in a lot of you know, environments and settings. Some work in clinical settings, some work in hospitals, some work in community-based settings, some work in, you know, in public health settings. So that's how it varies. And then there's a requirements of continuous education that peers are supposed to have in terms of for them to renew their certification. And I will talk about what is happening of the training now, what's happening with continuous ed. I will address those challenges, that question that people may have. We'll go to the next slide, and then we're gonna, Penny has a hand raised, so we're gonna bounce to there, yeah. Penny, you had a hand raised, yeah.
Oh, yes. So our CCO has expressed some interest in perhaps training myself and my coworker in being a trainer for certifying people for peer wellness and peer specialists. But we were unable really to find any information on how we could become a trainer.
So, good. Not to put you on the spot, and I will have Adrienne to jump in. She serves in one of the great subcommittees that the commission, the state has. Before I bounce it, maybe I'll toss it back to Adrienne. Do you want to unmute yourself and answer maybe to Penny? What should be better, I think, in terms of, take it on.
Yes, absolutely. Thank you. So Penny, I think one of the important things to know about how traditional health worker certification training works in Oregon is that there is no standardized curriculum that is used. So on the committee, the Training, Evaluation, and Metrics Program Scoring Committee, or TEMPS, which is such a mouthful of a committee name, what we do is review all of the training program applications for programs and agencies that are interested in becoming approved to provide traditional health worker certification trainings. So we do that for all of the different traditional health worker types, peer support, peer wellness, family support, youth support included within that. So there is online on the Office of Equity and Inclusion website, there is a training application that has all of the information about the review and approval process. So what an organization that was interested would do is, first, you would need to have a training program, a curriculum that has been developed and created for use with peers. And then you'd fill out that application, which has a number of different questions on it about experience related to training traditional health workers, making sure that there's really a key understanding of what the specific training role is that the organization is hoping to train. So let's say peer support in this case, making sure that the trainers really have an understanding of peer support and that there are folks with lived experience doing peer support who are involved in that training development as well. So keeping in mind that quote we've all probably heard millions of times, nothing about us without us. So we absolutely want to maintain that here as well. So then training programs submit that application, provide their curriculum, their materials to the Office of Equity and Inclusion, and we then review that in the Training, Evaluation, and Metrics Program Scoring Subcommittee. And that application is available online if you're interested in seeing what sort of information is requested there.
Okay. Brilliant. Thank you.
Lastly, I would also say, remember, these are not copy-paste. So what I always would say to people, if you want to model, and it's important, we have to have every training in every part of our state. And coastal trainings, for example, is really needed, other rural parts. What I would usually start with, there are a lot of organizations like MHO, MACBO, Fork Time, a lot of organizations that are listed on our website who also have this model of train the trainer that they already have, where they are willing to come and provide, and your organization can partner with them to really even bring that curriculum while you identify the peers who will deliver this training with the lived experience, with the understanding of the peer world, co-developing with them. And you can cater to coastal Oregon as far as, you don't have to reinvent the wheel. There's always trainers out there who do this work every day. It's like reaching out to them and say, hey, we would love a training here that we can run our own. Can we be able to use your curriculum? How does that work? It goes from there, and we're willing to connect you with people that may be able to go in. For the sake of time, I'm gonna cruise us through here because we have to shut up in 90 minutes. And I want to make sure we all get to the key points and questions that all of you may have. So here, simply, this is what, according to Oregon, this is how peers are defined in terms of their certification. Those are the list I talked about it, but I will dive in more. If you want to go to the next slide. So these are like some key provisions. I'm gonna talk a little bit here in depth, but one thing you need to know when we talk about peer certification, there's key elements like I talked about. The training is one of them. And then you come to the state certification. Once you finish your training, one other big thing I'm gonna mention is about grandfathering. So a lot of people may not know what we call grandparenting. So the essence of this is if you are someone who has been doing this work with prior lived experience in addiction, mental health well, and you understand it, and you have so many trainings prior, you don't need to go to another training to state to become certified with the state. You just need to grandfather, meaning you can document 2,000 hours of work volunteering, or you have done this work in either in a church, a basement, or anywhere, or even in an internship format, or you have done in volunteering somewhere. 2,000 worth of hours is what you need to be certified by the state to recognize your lived experience and the work you put in. And there's an application with the same application that someone with the training is the same application you're gonna use to say, I need to be grandfathered in. I can, I have the lived experience, I have everything. And if let's say you are seeking mental health grandparenting, you can do that. If you are seeking addiction, addiction grandparenting, you can do that. The 2,000 hours worth of work is the requirements. And then there's also recommendation letter from, former supervisor, pastors, or anyone you worked with, like can write for you saying this person has worked that. How do you prove the hours? Sometimes if you worked in a places, the HR people or people who you worked with can say, X, Y, and Z has worked this amount of hours in our agency or in our, place. That is a way to grandfather in. And then once we hear that, we'll be bringing in to do certification, submit your certification, and then, we will process it. As all of you know, we are a government, so any bit of things we certify, you are required to do background check. And I'm gonna talk a little bit of that in a little bit here for the sake of time. But what does the background check entails? One is required by law from everybody. And whether it's employment, even the state certification, we require background check. But what happens if you have a prior history of conviction or other things that are affiliated with your record that may impact the background check process? But then the state came up with a weight test determination, which is technically saying that, well, with your prior lived history and, with the conviction, that shouldn't stop you to become certified. So what we have is, we do have a weight test process where technically would be, it's a scale you're looking in. On the right-hand side, maybe it's the work you do. On the left-hand side is your prior history of the conviction or anything that's related to your, history or of crime or whatever. But then what happens the state will do would be this. You're saying, look, 4 years ago, 10 years ago, this is what has happened to me. Now, in 2020, this is what I have done. This is how I have shifted things a little over my life to help other members in the community. This is what I'm doing now. This is what I'm involved with. It is somehow relieving your trauma, but it's another way to jump through the red tapes of government, telling them, look, it is not who I was. If there was a stolen record on my record, that is not who I am today. These are all the good things that I have done. So then you submit that alongside with your application. The people in the background check will look this and determine, is this person the same person he was 5 years ago, or is this a different person we are talking to really want to certify? On the basis of that, they really certify people, looking the right hand over ways what your past was. And that is what the weight test purpose is. And then there are certain small exclusion lists that we call, that are no. If you have any of those, even with MacBook, as well as with the state certification, these are no, which is, 6 major crimes, which involves like murder, second-degree murder, I think, sexual penetration. One, I think, there's like a list of 6 major crimes that you commit. Those are like a no. But anything else beyond those 6 major crimes, they are all outweighed. They can be weight tested and then they can go. And then another things as well, the state has a contract with our addiction peer support recovery folks. We have a contract with MACBO where MACBO can do a background check for them for the addiction recovery folks, and then they can send us the information to us, which we have this contractual agreement with MACBO where MACBO will do the, the application screening as well as the background check for them, and they will give us the data of that person saying, this person has been vetted and screened through the background check through MACBO, and then with that, then those people will be certified for the adults addiction in our state register, and they will be okay to go in. Both ways are viable option. If you don't want to go with MACBO, you want to do the weight test, still you will be certified, as well as, you will be certified. If you don't have prior history, it's all long good. You don't need to do the weight test. It's only if someone with prior history has that things might come up, they want to mention ahead of time so that should not become an obstacle when they are getting screened for the background check. That is the whole purpose of it. And then there's a continuous education requirements that is required every 3 years. You are required to earn 20 hours of CEUs. These days, we have freed all because of COVID. You can get all online. It can be any from approved training organization from the state, anything else, and then, or it can be OHA approved training. As far as the continuous education piece you are taking has some kind of work related to the field you are involved in. If it's peer related CEU, take it, we will consider that. I know there's a hand for Rendell. You wanna go to the next slide, and then I'm gonna answer Rendell's questions. Yes, take it. Dene, sorry.
Sorry about that.
I didn't pay attention to them.
My question was, I have two questions. The first one is, if you have had a traditional health workers certification before and it lapsed, or you didn't recertify right away, which one would it be, the grandfathering or just a new application? How would that work?
So it depends, and this is a challenge we have with a lot of people out there. I'm like, killing us. So technically, what beyond 6 months, we now, like by law, it's like according to the rules, 30 days you abandon, you don't want to be back, be it, you are gone. But these days, what I did administratively, we said, beyond 6 months, if you still like in the lapsing area, you can recertify, you can submit your continuous education, we will consider that. Above 6 months, we require people, maybe 3 years is long enough. Maybe you are not doing that work. Go take a training and then you restart over. If you want a grandfather, you can grandfather in. But it's not a back door for like, you failed to your certification and you did not, resubmit. I mean, getting, continuous education for 3 years, 20 hours is like very minimum, but not everybody can, do it on time. So what we recommend is taking another training to get fresh in the field, because all of you know the world of behavioral health is evolving and changing over time. The same status quo, training might not be the same. There's a lot of new information added. So getting updated and getting the things and submitting initial application again would be the perfect one.
Okay. Yeah, it's just complicated with COVID and everything. We've had supervisor changes. We've had so many changes in our organization and so much turnover that we missed it. We missed the boat. And my manager did not bring it up until a few weeks ago. So, yeah.
Feel free to talk me offline, and my contact information will be here. I'll be happy to address. If it's more than 6 months, what can we do? We're trying to create some leeways here and there, but we also have this state obligation to make sure we're vetting people correctly. But overall, this is like the way certification work. I'm not gonna dive in here. This is how the grandparenting kind of goes in. And on your left side is the standard certification. You complete your training, you submit an application, you get background check cleared, and then you go to the state register. That's how simple as that. And then the grandparenting is the same there on the second left. But provisional certifications, people who have incomplete for example, they completed one part, but they just wanna, I wanna do this 1 year and see how it goes. We do, but I mean, above all, we never ever provide this kind of certification. I've never seen anyone choosing 1 year. It's been always 3 years that most people will certify for. Next slide. So this is what will happen after certification. You technically, once you get certified with the state, we put you on the state register where your contact information, like your name, is available there, that you are certified by a peer. It also have even a lot of other more data, like your county, which part of the city, which state, which part of the county you are available. So if some health systems or individuals that finish a training and get certified with the state, any CCO or anyone looking for peers, they can find the information there in their service area. Some people will leave their name and email there. Some people would put their name only. Some people put even their phone number, just in case. It's like a hub, a state registry. And even our Medicaid population, when it comes to billing, if they want to bet, if you are really certified, they go to this state registry. And that is the process so far it is that we undertake it through. Yeah. Next slide.
I believe this one is me.
It's your show.
All right. So first, I see a hand up from Joshua. Just wanted to check in and see if that was a question.
Yeah. I had a question. Can potentially answer it later, but I just know that there was like $64 million cut in like mental health services in Oregon. I was just wondering how that affects billing for peer support workers and traditional health care workers.
So the way it does work would be, I think, the state has several structures. One, all of you know that 90% of Medicaid dollars that the state get, it goes to CCOs, 90%. Only the 10%, we call it open card population, people who don't choose CCO, that they are in this bucket of, group that receive Medicare, and the state assigns them any health system like provider, legacy, Providence, or any hospital out there. But technically, that is like 90% of the bucket of Medicaid funding that the state gets from the federal, usually go to CCOs. But then addressing some of this bucket, like the money you talk to, what the state sometimes has is another structure where they will try to disperse this money to county health, departments that are in different parts of the state as a grant format, so that they can contract with peer-run organizations to deliver, to contract with community-based organizations doing the work to really channel this money to address it more deeper into the community. That's the kind of a structure sometimes the state uses. But I'm happy to filter through to get to you, connect with my behavioral health folks in the state to ask them how is this money really being dispersed. Sometimes they channel it through CCOs. Sometimes they will be making state grant funding to go to county behavioral health centers, so that the county can outward partner with CBOs, like community-based organizations, mental health centers, to really get the money, and then so they can continue to provide the services. That's how it kind of gets dispersed most of. But I'm happy to find more info for you.
Yeah, that'd be great. Thank you.
You're welcome.
Thank you. All right. So before I start talking about facilitating peer support supervision, I want to first acknowledge the resource and reference where the information came from that we're going to be talking about today. And that is from the Substance Use Disorder Peer Supervision Competencies. That was a document published in 2017, just a couple of years ago, by the Regional Facilitation Center, and a number of peers worked on that document and on the committees reviewing all of the competencies and information that was compiled there. So I just want to have a brief second to acknowledge and appreciate all the work that went into that. And that is available online for free if anybody is interested in looking more in depth into that peer supervision competencies document. So it covers 20 different peer supervision competencies. And today we're just going to look at a couple of them just in the interest of time, the ones that are more focused on recovery orientation. So the very first thing that is really critical to have within peer support supervision and as a peer supervisor is understanding the peer role. It is really, really so critical to have that strong understanding of peer roles so that effective supervision can be provided. And part of this is also having that lived experience of recovery or of mental health challenges as well. So one of the things that I find really helpful about the SUD peer supervision competencies is you can use it in your own work. So they have checklists for each competency that look at knowledge, skills, and abilities, or KSAs, and break it down. So I can go in there and go, okay, how am I doing in this area? Or maybe there's a couple things that I need to work on. So it can be something that is very practical in addition to educational. So recovery orientation is something that is also important to peer support supervision. Critical that the supervisor understands and supports the philosophy of recovery and recovery-oriented systems of care. You know, promoting things like hope, self-disclosure, mutuality, even the language that we use, making that person first, you know, working around empowerment and keeping peer services voluntary and directed by those that we are working with, keeping it person directed, you know, utilizing and really supporting, seeing the strengths in those that we work with. So all of these things are going to be important for a supervisor to have. And I understand that across the state, we're in different places related to peer support supervision. I hear from some peers in various parts of the state who may not have access to a supervisor, or they may see a supervisor very infrequently. So I want to acknowledge that sometimes happens. And then sometimes folks have a peer supervisor who not only understands the role, has that recovery orientation, has that lived experience, has that experience working within peer support as well. So we all can be in sort of unique circumstances depending on what our supervision looks like. And these competencies are designed to really outline what an ideal scenario would look like, what we would look for in terms of knowledge, skills, and abilities related to supervision of peers. We've got a couple more that I want to quickly cover here. And I'm just checking in to make sure we've got no raised hands or questions. And in this, we also want to model principles of recovery. So walking the talk or talking the walk. I always mix up the order of that phrase. But doing as we share and making sure that we are honest and truthful within that. You know, incorporating values, recovery values within the work that we do and how we connect with others, and also how we are as supervisors. Something else that's really important is a supervisor needs to support meaningful roles for peers. Sometimes I hear from folks who go, Adrienne, I'm not really sure what to do. It seems like in my peer role, I'm mainly grabbing coffee for people, or I'm mainly doing something that is not a meaningful peer role and is not in line with the peer scope of practice. So hopefully folks will be connected with supervisors who will support that meaningful role development within our peer scope of practice and in line with those peer and recovery values. And then the final competency from this SUD manual that we pulled from is recognizing the importance of addressing trauma, social inequity, and healthcare disparities. So supervisors need to understand trauma-informed care and the principles in line with that, incorporate that within supervision, and also understand and work around social and healthcare equities and promoting those. And so that needs to happen at all levels of the organization. And so I want to pause here and see if there are any questions before we go into opportunities for integration next. All right. I am not seeing any questions, so I'm just going to move forward into opportunities for integrating peer traditional health workers. So this can happen at the within coordinated care organizations, within counties, within other organizations as well. And so there are different roles that different partners can play in supporting the integration of peer support, peer wellness, peer recovery roles. So opportunities for coordinated care organizations and counties include partnering with community-based organizations, with peer-run organizations, to get feedback and input and really come to an understanding of what the community needs and what those organizations need, what we need in peer roles in order to be successful to do our jobs and serve those that we support as peers. It is also an important task at the county or coordinated care organization or governmental level to identify peer support disparities and look at those disparities and figure out ways to promote equity and reduce those disparities within the services that are being provided and the groups that are being served. Many times counties may elect to subcontract with community-based organizations or peer-run organizations serving specific communities, because just like in peer work, we believe that folks who have lived experience, who are a part of that community, have a special connection to that community and with that lived experience. So sometimes that work is not best done by a governmental agency or by a coordinated care organization, but instead by a culturally specific organization or another community-based organization that is really connected to serving a specific community. Of course, one of the important things is going to be the money, right? So providing funding to finance outreach, peer support activities, including utilization within other systems that might be child welfare, within local hospitals, within correction systems, drop-in centers, all different types of places. But it's important to have that funding available so programs can grow. And then those working within those programs can also be paid a fair and equitable wage. Community-based organizations also have a role in integration. So this is oftentimes where the training happens that we were talking about earlier. So within community-based organizations, we can train peers to be certified in all the various roles that we hold as peers, on how to effectively provide support, on how to navigate those complex systems that are out there that many of us work within from day to day. Community-based organizations can then employ and support peers to work within the communities that they serve and also provide quality supervision to the peers that are employed within the community-based organization. At the peer level, we then meet individuals where they're at and support them in exploring the goals that they set for themselves without bringing an agenda of our own. Just meeting people where they're at and walking alongside them in their own journey with the goals that they have set for themselves. As peers, we also provide ongoing support and system navigation, working with those individuals on those self-directed goals, even if they're transitioning from system to system or working with other folks for their services, we can be flexible. And the specifics of what this looks like can absolutely vary from organization to organization. You know, sometimes there are differences in how we work with people or how long we can continue to support our peers, things like that. That's something that can change from organization to organization. Then I also want to look at here the role of the community member or the person that is receiving the supports. So peer support is always optional. It's never something that I can be told you have to receive peer support. You must do that. And I think that's one of the things that's really so valuable about peer support is that we are not forced into receiving it. It is that person's right and that person's option to receive peer support. And at that same time, if I have a couple times that I meet with someone and they go, you know what, maybe I'm not interested in peer support right now. That's their right, and that's okay. And if they would like to connect in the future, we can be available for that as well at their direction, led by the person that we are receiving, that we are providing supports to and walking alongside. Peer supports can be an excellent way to provide culturally and linguistically appropriate services, making sure that folks have access to services in their preferred language and in a way that is respectful of and understanding of their culture. Community members that we work with can connect with us in the ways that work best for them. You know, some folks might want a regular check-in. Some folks might say, hey, you know, I'll be the one to reach out to you. That's what works best for me, as if I initiate that conversation. So it's all about learning from each person that we support what works best for them. And that's both a conversation and an exploration. And peer support is really an incredible way to connect with and support people, especially amongst these times where it was shared earlier, you know, all of these statistics and all of these kind of sombering facts about, wow, you know, Oregon, we're towards the bottom. Well, we are at the bottom of the list when it comes to mental health and addiction within our state and rates of that. And so the roles that we have as peers are really critical because we are supporting people where they're at. And I have seen so much recovery happen related to peer support. And I really think that is an amazing thing. So I want to pause there and see, we've got about 7 minutes left to see what questions there are from folks. And feel free, if you have a question, feel free to either unmute yourself or raise your hand and we can respond to questions there. There's also the chat box.
And can I just say one last quick thing that I think one thing I wanted to shout out on the state certification, it is more a bureaucratic process. So I just wanted to shout to all of you that when you submit an application, let's say to the state, remember, let's say you use a work email or anything like that. One, I always tell preferably use your own personal email. Don't use your work email. There are many million reasons and gillions reasons for that. The reason is like if you leave your job, the state will keep sending that email to your job unless you update to us. So the best way I always would advise people, use your personal email. Secondly, whenever you submit the application to the state, roughly now it takes a month to get back to people because of resources and COVID and other things. It shouldn't be that way. We are shifting to a way where people will enter their own application online down the road, maybe in 2021. I'm not optimistic about slow government, but we are getting there. But one thing I wanted to say, when you submit application, staying on top of your email is critical, because when we receive it, we send you receive the notice. But then when they initiate background check, you'll get an email from the background check, and you only have 14 days to respond. If you don't respond, you will close out. Meaning we wouldn't know that you did not respond to it, because we wouldn't go back to individuals looking each person all the time. We have about 4,000 workforce around the state, and it's about like 2 FTE that are doing this work, like 2 full-time people, about 4,000 people. You can imagine. So the resources are thin, so it's very important. If you submit an application to the state, please stay on the game of like watching the email all the time. That helps you to like get a faster. I have people get through like 7 days, and I have people who are like 2 years, because it is like they are not somehow checking things on time. When you close out, we have to also then reinitiate you again one more time to reopen the background check for you. And the background check is not done by us. It's a whole different unit outside of our division, outside of our packet, and they do even millions of background check for the state, from childcare to anything. So it's like you are in the midst of that, people. So staying on top of your game will help a faster, smooth process of certification. I just wanted to shout out that. And you know, my email is there. If you get stuck for whatever reason, I'm always available to respond by email, and I will answer your question within as much as I could in the same day or so. Thank you, and we'd love to take any questions from folks.
Thank you. This is Adrienne, and I see a couple comments that had come through the chat that I want to address. So these slides will be available. They will be posted up on the Pure Apocalypse website, as well as the recording. I want to let everyone know it will take a little bit of time before they're available, just because while the conference is ongoing, all of our team and all of our efforts are really focused on the conference while it's live. So it will probably be a week or two after the conference while we get all the recordings back from presenters and slides. For those presenters that have opted in and have consented to sharing their slides and recording with us, we can then get that up on the Pure Apocalypse website. So please look out for that, but those will be available. And then another question that I had seen was, do I need 20 hours or 40 hours of continuing education units for THW recertification for peer support specialist? You will need 20 hours within that 3-year period to renew.
If you are not a family peer. So I forgot that, but thank you for the person who asked that. If you are a family peer, the requirements like you get 40 hours of continuous ed to really understand what you are needed. And that was what the family peer movement wanted to do, and that's how it is. It's not something that the state came up with, but it was more around the family peer, network wanted to make sure people are well understood, have the knowledge and education. So if you are a family peer, you are required to have 40 hours of continuous ed. But if you are any other peer, like adults, addiction, mental health in our adult world, there's only 20 hours of CEUs.
Yes, thank you. And one other question that I had seen was, are there virtual initial peer support specialist certification trainings that are happening? So I think it was a couple months ago now, time kind of passes kind of strangely these days, it seems, but the Oregon Health Authority Office of Equity and Inclusion released a memo with guidance for training organizations, stating that training organizations who are currently approved can provide components of their training online that would still make sure that those trainees, that folks who are taking the training, are still going to leave with the same knowledge, skills, and abilities that they need in order to be ready to be certified within that specific training that they are looking for certification from. So I do not believe there are any 100% online trainings just because of that requirement to make sure that there is some type of in-person component for those sections that are really critical to becoming certified in peer support.
And one other thing we are doing, we came to realize all of you, COVID dropped in our while, no one knew what would happen, but at the end, what we're intending to do is make sure maybe with COVID around for a longer time, we are coming up with ways to really waive some of these challenges and concerns that people have to part of certification, because we may start having COVID until next year is what the projection is. So we are shifting how our continuous education requirements and trainings requirements may be moved a little bit around. So then down the road, we will not have any of these in-person requirements. That's the place we are leading to, since we know no more in-persons will be around. So you don't need to code your certification, just document those hours and then have it available and ready, showing them the proof here.
Thank you. And the other question was just asking for your contact information, which is mohamed.abdiasis@dhsoha.state.or.us. And that's listed up here on this slide as well. So I hope everybody is able to see that okay. And we are coming up on 10:30 Pacific, 1:30 Central Time, 2:30, if my math is right, over on the East Coast.
Yep.
So all that to say, we're coming up to where we need to wrap this presentation. I want to thank everyone so much for being here today with us, and really appreciated all of the questions and thought that you all had. These slides, as well as the recording of this workshop, will be available online on the Peerpocalypse website, probably within the next week or two. But thank you all so much for being here today.
Thank you.
Thank you. All right, so I am going to close this meeting room. So thank you so much, and hope to see you all in another workshop. Thanks. Bye-bye.
Bye.